Today, we are meeting a new patient who has come to us with recent reports of weakness and some trouble with their balance. Our goal is to perform a quick, efficient, and informative neurological screen. We will focus our attention on 4 key areas that tell us a great deal about the nervous system's function: muscle tone, deep tendon reflexes, balance coordination. This step-by-step guide is designed to feel like a live clinical demonstration, helping you move through the assessment with confidence and clarity. We will work methodically, ensuring our patient feels safe and informed throughout the entire process. Before we touch the patient or begin any test, our first priorities are always safety and consent. We begin by seating our patient comfortably on the edge of a sturdy examination plinth or bed. We must ensure the surrounding area is clear of any obstacles to prevent trips or falls. We start by asking simple but crucial questions. Are you experiencing any pain or dizziness right now? We then clearly explain each component of the exam before we perform it, ensuring there are no surprises. We then proceed to ask for the patient's consent to proceed with the assessment. This is a non-negotiable step. A simple phrase like, "We're going to check some of your muscle movements and reflexes now. Is that all right with you?" establishes respect and empowers the patient. If we anticipate testing their standing balance, this is the moment to apply a gait belt snugly around their waist. Our first hands-on test is the assessment of muscle tone. The primary goal here is to feel the amount of tension or resistance a muscle has to passive movement. Think of it as checking the muscle's readiness to act. Is it overly stiff and resistant, or is it floppy and loose? We need a baseline feel. To do this, we position the patient so they are completely relaxed, sitting, lying down. It is absolutely crucial that we fully support the limb we are examining. We gently hold the limb, cradling the forearm and hand. Then we begin to move it through its available range of motion. Start by moving the joint slowly and smoothly. Take the shoulder, elbow, wrist, hip, knee, ankle through flexion and extension. Pay close attention to the feel of the movement. Normal tone feels soft and yields smoothly throughout the range. It offers minimal, almost fluid resistance, consistent and predictable. After the slow movement, repeat but vary the speed. Move the limb more quickly. Some increased tone, like spasticity, becomes more pronounced with faster movement. Always compare one side of the body to the other. Abnormal findings fall into 2 categories: increased tone, decreased tone. Increased tone, or hypertonicity, is stiffness and resistance to passive movement. If resistance increases with speed, and you feel a distinct catch followed by release, that suggests spasticity. Spasticity is common with upper motor neuron lesions. For quick notes, document increased tone, or use the modified Ashworth scale for grading. Decreased tone or hypotonicity makes the limb feel heavy, loose, and floppy, like a rag doll. Practical tips: focus on one joint at a time. Side-to-side comparison is essential. Use the slow then fast sequence when you suspect spasticity. For a quick screen, simple descriptions work. Tone appears normal throughout. Mildly increased tone noted in the left elbow flexors. This gives a clear functional picture of the patient's status. Next, we move on to testing deep tendon reflexes. The purpose of this test is to assess the integrity of the reflex arc, which involves the sensory nerve, the spinal cord connection, and the motor nerve. An abnormal reflex can give us important clues about where in the nervous system a problem might be located, particularly pointing toward potential upper motor neuron involvement. To set up, the patient should remain in a relaxed sitting or lying position. The limb we are testing must be supported and the muscle group completely relaxed. We use a small reflex hammer to deliver a quick, brisk tap directly onto the tendon. Success here depends on a relaxed patient and a precise strike. We focus on a few key reliable reflexes. For the biceps reflex, C5 to C6, we support the patient's forearm, place our thumb firmly on the biceps tendon in the elbow crease, and strike our own thumbnail. We are watching and feeling for a quick contraction of the biceps muscle and slight elbow flexion. For the triceps reflex, C7 to C8, we support the patient's upper arm so the forearm hangs loosely, and we strike the triceps tendon just above the elbow, looking for elbow extension. The patellar reflex, L3 to L4, or knee jerk, is tested with the patient sitting and legs dangling freely. A tap on the patellar tendon should produce a brisk knee extension. Finally, for the Achilles reflex S1, we support the foot in slight dorsiflexion and tap the Achilles tendon, watching for plantar flexion. We grade the response on a simple numerical scale, most commonly from 0 to 4+. A grade of 2+ is considered normal and is what we expect to see. A grade of 0 means the reflex is absent. A 1+ indicates a diminished or hypoactive response. A 3+ is a brisker than average or hyperactive response. A 4+ is a very brisk response that is often accompanied by clonus, which is a series of rhythmic, involuntary muscle contractions that you can feel or see after the stimulus. The symmetry of the reflexes between the left and right sides is often more clinically significant than the absolute number itself. Asymmetry is a red flag that warrants further investigation.
If you cannot elicit a response, the patient may not be fully relaxed. Use a reinforcement technique, the Gendrasik maneuver, or ask them to squeeze their thigh for upper limb reflexes. This cognitive distraction increases facilitation throughout the spinal cord and can make a subtle reflex appear. When documenting, be concise. Reflexes 2+ and symmetrical throughout, except left Achilles 3+, with 2 beats of clonus.
Now that we have assessed the patient while they are comfortably seated, we transition to evaluating their balance. The purpose of balance testing is to assess the patient's ability to maintain their center of gravity over their base of support, both when still, static balance, and when moving, dynamic balance. This complex skill relies on input from the visual, vestibular, somatosensory systems. We begin with the simplest test, static sitting balance. We ask the patient to sit on the edge of the plinth with their feet supported on the floor and their arms crossed over their chest. We then time them for 30 seconds, closely observing for trunk sway, loss of posture, or need to use their hands for support. Next, we progress to standing balance tests, ensuring we are standing close by with the gait belt securely in hand. We start with quiet standing, asking the patient to stand with their feet together for 30 seconds, first with their eyes open. We watch for the amount and direction of their postural sway. Then, we perform the Romberg test by asking them to close their eyes in the same position. A significant increase in sway or a loss of balance with eyes closed suggests a heavy reliance on vision and a potential issue with the somatosensory or vestibular systems. We can make the task harder with a tandem stance, asking them to stand with one foot directly in front of the other, like on a tightrope, again for 30 seconds. For a more functional assessment, we can test their single leg stance. Let's see how long you can stand on one leg. We will try it on both sides. We time how long they can maintain their balance without touching the raised foot down or grabbing onto something for support. This is an excellent screen for assessing stability and identifying asymmetrical weakness or poor motor control. After static tests, we move to dynamic balance. The timed up and go tug test is a fantastic tool. We time the patient as they stand up from a chair, walk 3 meters, turn around, walk back, and sit down again. This simple task incorporates multiple transitions and challenges their balance in motion. Throughout all balance testing, safety is our absolute priority. We must act as a human guardrail, always positioned to prevent a fall. When documenting our findings, specificity is key. Instead of just writing poor balance, we should be descriptive. Note the time held for each test and the amount of assistance required. Example: static sitting, stable for 30 seconds without support. Romberg test, positive, with significant sway and near loss of balance after 5 seconds. Tug, completed in 22 seconds with standby assistance required during the turn. After assessing balance, we investigate coordination. The goal here is to evaluate the quality of voluntary movement, speed, rhythm, smoothness, accuracy. Coordinated movement requires the cerebellum to work in harmony with the motor cortex. and sensory pathways. Deficits in coordination, often called ataxia, can significantly impair a person's ability to perform everyday tasks. We can test coordination in the upper limbs. For the upper limbs, the classic finger-to-nose test is highly informative. We sit in front of the patient and instruct them, "We're going to play a little pointing game. I want you to touch your nose with your index finger and then touch my finger." We hold our own finger out at about arm's length and move it to several different positions. We watch for a smooth, direct path. Does their finger travel straight to the target, or does it waver and zigzag? Do they overshoot the target, or undershoot the target? Dysmetria. We also look for an intention tremor, a shaking that worsens as the finger gets closer to the target. Another key test for upper limb coordination is rapid alternating movements. This test specifically looks for dysdiadochokinesia, the inability to perform rapid alternating movements smoothly. We give the instruction, "Please place your hands on your thighs." Now, as quickly as you can, we're going to tap your thighs, first with your palms down, then with your palms up, back and forth, like this. We observe their performance for breakdowns in rhythm, slowing, or irregularity. A person with cerebellar dysfunction will often struggle, with one hand performing much more clumsily or slowly than the other. For the lower limbs, the heel-to-shin test is the standard. With the patient lying on their back, we ask, "Can you please take the heel of one foot and place it on your opposite knee?" Now, slowly and smoothly, slide your heel all the way down your shin to your ankle. We have them repeat this a few times on each leg. We are observing for the same qualities as the finger-to-nose test. Can they keep their heel on the shin, or does it slip off? Is the movement smooth and controlled, or is it jerky and wavering? Dysmetria in this test is a strong indicator of ipsilateral cerebellar disease. A concise documentation note might be, coordination, finger-to-nose intact bilaterally. Mild dysmetria noted on left heel-to-shin test. We can test coordination in the lower limbs. These tests are designed to reveal subtle impairments like tremors, overshooting, or clumsiness. Section 6. Safety. First, documentation. Always guarding and recording your findings. Throughout this entire neuro screen, our most important role is to be a safety officer. Protecting the patient from harm, especially preventing falls during balance testing, is paramount and non-negotiable. This means using a gait belt, standing in close proximity, and maintaining a state of constant readiness to provide physical support. We should always choose the test environment carefully, ensuring it is free from clutter. When asking a patient to perform a challenging task like a single-leg stance, it is wise to have them stand near a wall or a sturdy counter just in case. Clear communication also enhances safety. By explaining what you are about to do, you prevent sudden, unexpected movements that could lead to instability. Once we gather our findings from each domain, tone, reflexes, balance, coordination, we must connect the dots. These individual results rarely exist in isolation. Together, they form a pattern that helps us formulate a clinical impression. For example, increased tone, spasticity, hyperactive reflexes, 3+ or 4+, and perhaps an upgoing toe on a plantar reflex test, Babinski sign. This cluster of findings strongly suggests an upper motor neuron lesion, such as one might see after a stroke or spinal cord injury. Conversely, decreased tone, reduced or absent reflexes, and significant muscle wasting points more toward a lower motor neuron problem, like a peripheral neuropathy or nerve root compression. Clear, concise, and objective documentation is the final piece of the puzzle. Our notes should be a clear record of what we did, what we found, and what it means. Avoid vague terms like good or bad. Instead, use objective measures and descriptive language. Patient alert and cooperative, seated at edge of bed. Tone, moderate increase in right elbow flexors, consistent with Ashworth 2. Reflexes, patellar reflexes 3+ bilaterally, Achilles 2+ on right, 1+ on left. Balance, tug completed in 14 seconds with minimal assistance for turn. Coordination, mild intention, tremor noted on right finger to nose. Let's look at 2 brief case examples to see how this comes together. Case 1. John, a 68-year-old male, 2 weeks post-stroke. Our notes might read, sits with moderate right lateral trunk lean. Tone, increased right upper extremity and lower extremity versus left. Reflexes, 3 plus right patellar, 2 plus left. Balance, unable to perform single leg stance on right greater than 1 second. Impression, right-sided hemiparesis with spasticity and impaired standing balance. Plan, focus on symmetrical weight-bearing, gait retraining, and hip extensor strengthening. Case 2. Maria, a 45-year-old female with dizziness. Notes, tone within normal limits. Reflexes 2 plus symmetrical. Balance, wide-based gait pattern. Coordination, moderate dysmetria on bilateral finger to nose and heel to shin. Impression, ataxic presentation suggestive of cerebellar involvement. Plan, refer to neurology for further diagnostic imaging. Initiate fall prevention strategies. Section 7. Conclusion, synthesizing the clues and charting the course. In summary, performing a focused neurological screen for tone, reflexes, balance, and coordination is a fundamental skill for any physical therapist. It does not need to be a long, drawn-out process. By following a logical and systematic sequence, we can efficiently gather critical information that directly informs our clinical reasoning and treatment planning. The process begins before we even touch the patient, with a commitment to creating a safe environment and establishing clear communication and consent. From there, we move methodically from passive assessments like tone, reflexes, to more active and challenging tasks like balance, coordination testing, always comparing one side of the body to the other. The true value of this examination lies in pattern recognition. An isolated finding, such as a single brisk reflex, may not be significant. However, when combined with increased tone and impaired coordination on the same side of the body, a clearer clinical picture begins to emerge. These patterns help us generate a hypothesis about the underlying cause: upper motor neuron lesion, a cerebellar issue, or a peripheral problem. This understanding elevates our practice to targeted, patient-specific interventions. The findings from our screen are the building blocks of objective documentation, allowing us to track progress, justify care, and communicate across the team. Take-home points. 1. Safety and clarity. First, always begin by ensuring a safe environment, explaining every step of the process to your patient, and obtaining their consent. Use a gait belt for all standing assessments. 2. Compare and contrast. The most valuable information often comes from comparing the left side to the right side. Asymmetry in tone, reflexes, or coordination is a significant finding that should always be noted. 3. Document to guide. Use your specific, objective findings to build a clinical impression. This impression should directly guide your treatment plan and help you determine if a referral for further medical evaluation